Move to the last of the presentations from Professor Uwe Zeymer, and this is Preservation 1, Bioabsorbable Cardiac Matrix for the prevention of remodeling of the ventricle after large ST segment elevation MI. And Uwe, I must apologize that I've got a presentation in another session, so I'm going to have to run partway through.
Okay, but we'll hear it in the afternoon. So, yeah, thank you. These are my disclosures. It's well known that despite the widespread use of primary PCI, a number of patients will have a large myocardial infarction. And the problem with this patient is that they will have left ventricular remodeling, which further impairs their cardiac function. And at this slide, you can see that the larger the end systolic volumes, the higher the probability of experiencing heart failure or mortality during follow-up. And in this study, we really studied a new approach to prevent left ventricular remodeling. In large infarcts, you have seen a degradation of extracellular matrix and calcium overload. And this device we used in the trial, which is called bioabsorbable cardiac matrix, is a combination of an alginate and calcium. It's biological and immunological inert and does not undergo metabolism in the body. Therefore, it's called a device. In the presence of calcium, PCM turns to a flexible hydrogel, and this gel replaces the extracellular matrix, thickens the infarct zone, and reduces wall stress. And in experimental models and in a pilot trial, PCM was able to provide mechanical support and prevented consistently remodeling. Therefore, the trial hypothesis was, can the intracoronary deployment of an inert bioabsorbable cardiac matrix replace the damaged extracellular matrix and provide a temporary physical support during infarct healing and repair, and can this device prevent remodeling? This is a trial organization, and this is a trial design. So we looked for patients after successful primary PCI, and then we screened the patient, and we included patients with a large infarct defined as high peak cardiac markers, as a clinical presentation with delayed PCI, ECG changes or shock, and on imaging, they had to have a large infarct with an ejection fraction of less than 35% or an MI size of more than 20%. And then the second procedure was done where the device was deployed, and patients afterwards were followed for 6 months, and then the primary and secondary endpoints were obtained. The primary endpoint was a change in left ventricular anti-diastolic volume index from baseline to 6 months, and we have calculated that we need about 276 pairs to detect a difference of 5 ml, which is deemed to be clinical relevant. We have chosen echo because it's as accurate and reproducibility is equivalent to cardiac MRI, and it had some practical advantages. We had some clinical secondary endpoint in this trial. So what did we do? The deployment procedure 2 to 5 days after the primary PCI. First, patient had to have TIMI-3 flow in the infarct-related artery, then an intracoronary injection of 4 ml PCM or saline control. So we had a sham procedure in this trial was done, and the deployment was performed via a dedicated catheter just proximal to the stent of the infarct-related artery. We enrolled over 370 patients. From these, 300 were randomized, so we had enough power. We assumed a dropout rate of 10%. Actually, we were able to have the primary endpoint in 95% in the BCM group and 91% in the saline group. With respect to baseline characteristics, there were no major differences with respect to age, diabetes. Most of the patients had anterior MI. The group receiving BCM had somewhat larger infarcts with left ventricular ejection fraction a little bit less than in the saline control group. They had larger infarcts by imaging. They had a higher NT-proBNP, and the end diastolic volume index was so much larger, higher in the BCM group. They were well treated with respect to the use of secondary prevention therapies. And here's a primary endpoint, left ventricular ejection diastolic volume index after 6 months. And you can see here that there was an increase in left ventricular and diastolic volume index in both groups, but there was no difference between the saline control group in red and the BCM group in blue. And this was true not only after 6, but after 12 months as well. With respect to clinical endpoints after 6 months, again, we did not observe any differences between the two groups with respect to 6-minute walk test, improvement in NIHA class, or the number of cardiovascular hospitalization, nor death, nor the combined endpoint. With respect to safety parameters, we looked for a composite of cardiovascular death, acute MI, revascularization, stent thrombosis, severe arrhythmias, or myocardial rupture. And again, we did not observe any difference between the two groups until 6 months or until 1 year. Since we had to do a second procedure, we looked for procedural safety. It has to be said that 1/5 of the patient had a staged PCI during this deployment of the device. However, we had seen no difference between BCM and saline on arrhythmias on a 24-Holter ECG, nor any increase in ischemias. There were some more transient occlusions in the BCM group, but only 3 of these patients had ischemia on Holter. So, in conclusion, in this trial, we were able to identify and to enroll patients with large MI. The deployment procedure of the BCM 2 to 5 days after primary PVI was well tolerated compared to saline control. It's clear that the additional invasive procedure carries risk, but this was minimal, at least in our study. However, in this patient population with really large STEMI, intracoronary deployment of BCM does not prevent left ventricular remodeling compared to saline control, nor did it reduce the occurrence of heart failure. So what's the reason for the discrepant findings compared to the animal data? It might be that our patient population was just too sick, that they had too large infarcts, or it might be that the timing was too late, that we had to deploy the device earlier to prevent remodeling. It might be that we had some technical problems, that we need more of the device, or that microvascular obstruction prevented the device to go in the infarct zone, and we have to do further studies to really have more insight in the technique. Last but not least, I want to thank all the patients and the investigators who enrolled patients in this difficult to perform trial. Thank you very much.